So hello everybody to Planet PCR, the interactive discussion forum for sharing experiences of the COVID-19 pandemic around the world. My name is Bernard Prendergast in the UK, and I'm very pleased to be joined by Maciej, my friend and colleague in Poland, and Lars Sondergaard in Denmark, Scandinavia. So turning to you first of all, Maciej, could you tell us how things are with COVID-19 in Poland right now and how it's impacting on practice in your own hospital?
Hello, good morning everybody. The first patient was diagnosed with COVID-19 in Poland in the beginning of March. It was March 4, I guess. But we closed down, we locked down almost the whole country very quickly. So as in many countries now, the schools and restaurants, supermarkets are, apart from groceries, are closed. That's why the dynamics of the disease is not that high. So now, until now, we have 5,500 diagnosed patients, and mortality is this case fatality ratio is around 3% now. 174 patients, as for yesterday, died. So the situation is not that bad. We still have a good supply with ventilators. Hospitals are not overwhelmed yet. So I think as compared to other countries, we are not in a very bad shape currently.
And is it the same in Denmark at the moment right now, Lars?
Yeah, I think it's the same restrictions as in Poland. So it's been a very limited number of mortality. It's about 40 per million who's died so far. And also for the ICU, it's been a maximum of about 120 people on ICU, and they have a capacity up to about 1,000. So it's far below what you could fear. And also the numbers has been declining every day for the last week.
So you're both grappling with a very different situation, let's say, from our colleagues in Italy and Spain, or even here in the UK, and certainly very differently from the situation in China or potentially in India, where huge numbers could potentially be affected. It seems like a different picture for you both. Would that be the same across Eastern Europe and across Scandinavia? Maciej, what do you think?
Yeah, I think in most of the countries around us, like Czech Republic, Slovakia, and other countries, the situation is not very bad, because based on the, experience of a very sad experience of Italy, our governments reacted really, really very promptly. So we with the complete lockdown of all, of course, and then setting the social distancing very, very early. And so I think that's the result, that we had time, to observe and to draw some conclusions.
So it would seem, Lars, there hasn't really been a resource issue. What have you done about elective and non-elective pathways, for example?
I mean, for cardiology, most disease are regarded as critical disease. So you have to treat patient, otherwise you're going to increase your waiting list and patient is going to die on the waiting list. So far we're doing the normal program. Of course, keeping in mind that if ICU is going to need more capacity, we have to reduce it. But it hasn't been the case so far. But as an operator, we only at the hospital the day we're doing the procedure. Otherwise, we stay home and try not to get the disease at the same time, all of us.
Yeah, so you're getting very skillful at Skype telephone conferences and so on.
Yeah. And with no traveling, you're spending a lot of time at home.
Exactly. So Maciej, what about the approach in Poland with COVID negative and COVID positive centres or areas within the hospital? How is it working out across the network?
Yeah, almost since the very beginning, when the disease was diagnosed in the first patient, we set up a network of COVID-only hospitals. So there are 21 such multidisciplinary big hospitals in a country. And they admit all patients with diagnosed COVID or very suspicious of having, COVID disease, with multiple, disease, of course. Whereas my hospital, which is a big university hospital with 430 beds, we work as a regular hospital. And as Lars mentioned, we treat all the patients, including elective procedures, not only urgent patients like acute MI or acute pulmonary embolism, but also elective procedures, because I think that those patients really need a proper treatment, and we don't want to deprive them of a good approach and good treatment, and don't let them die in a waiting list. Of course, we don't have to treat everybody, because people with CTO, for example, just diagnostic coronary angiography, as long as they are stable, they can wait. It can be, the procedures can be postponed, but otherwise we know very well from not only from Italy, but also some other European centers and American centers that we know we see the excess of deaths, and the COVID-19 cannot be exclusively blamed for the big excess in a death rate what we observe now. So I think many patients die because they are just afraid of calling ambulance or looking for help. Yeah. So this is really important, not to forget about non-COVID patients.
Yeah, I mean, that's something we've seen very acutely in London, that there are just virtually no ST elevation MIs and no acute strokes. It's extraordinary. Are you seeing the same in Copenhagen, Lars?
Yeah, it's the same concern, and people are encouraged by the media to seek doctors if they have any symptoms. But it's the same also for the TAVI program. Quite a few patients who is on the waiting list decline to come in for the treatment. They don't want to go to the hospital. So it's going to be a balance. It's easy to get fear into the population. It's much more difficult to get them back to normal behavior.
Sure. And what about your surgical colleagues? In many centres, in busier in countries where there is more COVID, cardiac surgery has been suspended, except for the utmost emergency. What's been the reaction in both of your countries?
In Poland, in my center, planned surgical procedures are not stopped because this is government decision to postpone all procedures that might require a longer stay on a ventilator, on a respirator. Yeah. So like acute aneurysms and people with really severe coronary artery disease, the subtotal left main disease and triple vessel disease, but they are almost only emergencies, which is not so for us. So we treat more elective patients like our colleague surgeons.
And yourself, Lars?
Yeah, but the heart surgery is unchanged as well in our institution. I mean, again, you don't know how long this is going to last. You can't really put them on the waiting list. I got the impression that patients, let's say, with aortic stenosis who had maybe a high risk for surgery is more likely now to come for a TAVI procedure to not to get stuck on the ICU.
Yeah, and are you doing all your heart team discussions virtual format?
We actually do it, yeah. We do it mostly face-to-face, but also some of them as a virtual meeting.
Okay, it's interesting, isn't it, how indications for procedures maybe are subtly changing, and the balance between open surgery and transcatheter might be subtly influenced by the medical circumstances. Yeah. So you're both working in countries where things seem to be very much under control, and obviously there's been a lot of discussion around different governments' approaches to the threat of the disease. What do you see looking forward in the future? Are there potential worries down the line in countries where there isn't much COVID-19 now, but it might be a problem in 12 months' time? Do you have perspectives to offer?
Yeah, what I'm afraid of is, just, a kind of a second wave after we, loosen the regulations, which are not very strict, and nobody, will sustain with such a strict regulations for a longer time. There may be some second wave. There may be that the virus will mutate, and as it happened with SARS or MERS, it will be not that, dangerous for patients and for people. So there are, very optimistic scenario, very pessimistic scenario. What I observed recently is more going towards, optimistic scenarios, that perhaps the death toll will not be that high. But until, the next year, we have the exact, statistics, exact data from mortality for the given region, I think we will not know what was really the death toll of, what is really a death toll of this of disease.
What do you think, Lars? Project 1 year from now.
Yeah, I think maybe we are too efficient in Poland and Denmark. There's too few people among the population who's actually getting immune, so we're much more likely to have a second wave. And in Sweden, as you probably all know, it's a different strategy. Schools, universities are open, restaurants are open, shopping centers are open, to try to get immunity among patients who are at low risk for the disease. And maybe that's a better strategy, but it's a very delicate balance between not to crash the health system.
Yeah. Well, nobody knows the future, of course, but it's important that we all remain positive, and we hope that it won't be too long until we can all be together again in the PCR family and interacting in the normal way. But meanwhile, thank you both for joining us this morning, for sharing your experiences from countries that at the moment aren't too heavily burdened by the pandemic. And we hope that remains the case for you both and for all of your colleagues. Thank you so much for joining us.
Thank you so much. Thank you.